I welcome you all to Decoding Respiratory Medicine. Thank you so much, Doctor, for giving your valuable time to teach us about the chest strain. I'm handing over this mic to Dr. Arshad. Please continue.
Thank you so much, Dr. Sidra. My name is Dr. Arshad. Guys, I'm one of the specialty registrar working in respiratory medicine at Sandwell in West Birmingham Hospital. We are bringing you a pretty important topic of chest brain insertion, its indications, contraindications, and various steps. Hopefully, this will be very beneficial for you practically and academically, I think. So if we can just bring up to the next slide. So I've prepared some important slides for you guys. So coming toward the indications of chest drain. So I've just split it into two things. It's just part of your memory that we normally split it into for pneumothorax and for pleural effusion. So for pneumothorax, you need to keep in mind whether it is like spontaneous pneumothorax. Is it falling into the primary or secondary? I will bring up in the next slides in traumatic pneumothorax. And then coming toward fluid collection, that is like part of simple pleural effusion or complex pleural effusion as part of empyema. That is like a complex parapneumonic effusion as well. And then to consider the malignant pleural effusion, that is we normally observe in our day-to-day practice when we are dealing with lung cancer patients or malignancy of any other viscera that is causing some malignant pleural effusion as a result. And some patients, they do have pleural effusion as a result of some surgical procedures, or even after medical thoracoscopy surgical procedures, we need to insert drains for that recovery phase. Next, going through the procedure, I would remind everyone, I think you guys are very well aware of all the medical procedures, contraindications need to be very well known. Patient preference, we are always discussing the patient, starting with the capacity of the patient, whether it has, and if the patient is, if the procedure is in his best interest, whether we need to continue without getting the consent of patient. But if the patient has capacity, we need to get the consent. What are the alternate ways of management, and what is the patient preference? If he prefers to go with the intercostal drain, then definitely we need to intervene. Then to consider bleeding disorders. If the patient is already on anticoagulants, you need to keep in mind. And the other thing is always check the INR. And if platelet count, if it is less than 50 or INR is more than 1.5, you need to wait for a certain time. If the patient is already on anticoagulant medications, you need to withhold or suspend the medications and then to recheck. Don't intervene like on urgent basis if it is not necessary. That could complicate the procedure as compared to giving benefits to the patients. I would like to remind my all colleagues who are working in emergency medicine, so if you are just looking at a large air collection in the chest cavity on simple chest X-ray and you are worried about whether the patient has underlying undiagnosed COPD sometimes, and they have large bulla specifically in apical regions, so make sure with CT thorax to confirm it, because we have observed if sometimes we are inserting drain into the bulla that could lead to bronchopleural fistula, and that is very difficult to manage and to treat it later on. At the point of insertion, if there is skin infections, you need to be very well aware of. You need to inspect if at the site of insertion there is like safety triangle, if we're going and there is skin infection over there, you need to avoid that specific area. So these are like simple things to keep in mind before doing the procedure. Here we have just kept a slide for you guys to keep in mind the time duration for the anticoagulants. You need to withhold or suspend anticoagulants. So I'm always keeping in mind with the word of WCs, that is like important thing for 7 days, and DOAC specifically for 48 days, any patient who is on DOACs, normally being used or apixaban, rivaroxaban or edoxaban. So you need to suspend 48 hours before the procedure, and warfarin and clopidogrel should be suspended for at least 7 days before any intervention for the procedures. I'll let you know in the next slide about the steps as well, but keeping in mind the procedure, you need to start with initial consenting the procedure after getting the full idea why we are going to intervene, but why is it important and necessary for the chest drain to be inserted, then you need to look for the location either through chest x-ray, or if you're competent enough to go through ultrasound scans. The side is very important to avoid any sort of like errors or complications later on to development of any complications of the procedures. Thoracic ultrasound guided marking if it is the procedure for pleural effusion or fluid collections over there. And then looking at the patient's attitude, if the patient is very agitated, whether you need to go with pre-medications in the form of Oromorph or midazolam that just keep a bit calm and comfortable during the procedure. Important thing is your environment. If you are going to do the procedure in acute medicine in wards, normally we do here in pleural clinic, that's a proper environment where we have all the equipment ready over there and we have well-trained nurses. I think you made a proper presentation with Leona. She's very competent nurse for us. Then is important thing is post-procedure documentation, so that I always emphasize on what you guys have done. Probably the patient is moving to surgical department or some other departments, so they are not very well aware of how they will care in the ward. So documentation is very important. I'll bring up the thought in one slide. So what ideally should be in terms of observations or other documentation for that. And then the last thing would be drain removal. If you have achieved your goal, the patient has resolved in terms of like pneumothorax or pleural effusion, then what will be the stage of drain removal? How you'll be confident, okay, this is the point, you can remove safely the drain. Initiating the procedure, you need to keep in mind for pneumothorax, always we prefer to go in the safety triangle. So I think anatomically, you need to be very well aware of. I think you guys are aware of like regarding the safety triangle, anatomical borders, fifth intercostal space at the base, apical like apex is on the top, and lateral border of pectoralis major and lateral border of latissimus dorsi, and the central space like second, third, and fourth rib spaces are the safe triangle to insert any drain for pneumothorax. But in terms of pleural effusion, if you are thinking of inserting the fluid in drain for any fluid, so then you need to do ultrasound to mark at point of insertion. It's not always the safety triangle because fluids are normally collected at the bases, and you need to look at with the fluid collection. Maximum fluid collection is on the posterior aspect or on the lateral aspect, and where will be the major depth and what should be the point of insertion, and it should be ultrasound guided. And the position of patient for pneumothorax, normally and ideally in a spine position with lateral in the spine position at maybe 45 angles, so that would be an ideal position for pneumothorax. But in case of pleural effusion, the patient could be in sitting position like as shown in the picture, or the other position, even in lying position. You can go with the mid-axillary line approach as well. So this slide, I have prepped it for my ICD course as well, just for all of you guys to keep in mind. So as we are going through any examination, so these are 7 steps. So just keep in mind the resting station and the acting stations. So 3 steps before the resting station and 3 steps after that. Starting with the consenting and local anesthesia for the procedure. Now we are discussing about the procedure, and you have just prepped each and everything. You have finalized that you are going to intervene that procedure, consenting, and then to insert local anesthesia. Normally, we are using 1% or 2% of lignocaine, depending on the patient's. Like if you think the patient is more agitated, restless, and you need to go with, and depending on the pain threshold as well for the patient to clear up. And the dose for lignocaine would ideally be a 3 milligram per kg body weight, so we can just measure it, and then we can insert. I think the procedure is a bit technical thing. When you're inserting lignocaine, you need to just insert and then to withdraw 1 centimeter back and then to infiltrate like includa. That's a technique which you need to be aware of before giving local anesthesia for that one. And then next thing would be introducer. So if you're inserting for pneumothorax or pleural effusion, the aspiration kit which you are getting, normally it is coming up with dilators and introducer and drain and guide wire as well. So introducers are in it, where you can just measure the depth of the chest cavity along with the green needle through which you have inserted the local infiltration of local anesthetic agent. And then you can measure the depth of chest, and according to that depth, you can introduce your introducer and insert your guide wire. After introducer, when you are sure that you're in pleural space in the form of pneumothorax, you will get bubbles over there in normal saline in your syringe, or the fluid collection. If you've got fluid, strocal fluid, and you're sure you're already in the pleural cavity, and then you need to slide guide wire through this introducer. Once your guide wire is in, and on guide wire, because we are not going through the proper procedures, that will be a video link. Probably I will ask if we can share it later on. So there are some markings as well, 10 centimeter, 20 and 30 centimeter. Normally we need to go with 30 centimeter. So that will be according to the chest size and depth as well. And after making sure that 30 centimeters guide wire is already in, then you are a bit sure you can take the introducer out, and that is the resting station actually. So now you have achieved a goal, you have inserted the guide wire, and next step would be to do dilations and then to put a drain in. For dilations, pneumothorax would normally have like one dilator because it's like only 12 French intercostal drain which we are inserting. So it's only one dilator which we are just inserting and dilating in clock and anti-clockwise and just inserting in. While for pleural and empyema, there are three dilators because of just making a wide bore tunnel over there. For drain of 18 French, we need to just insert this 18 French drain. And then once you're draining, then you need to be sure, at least according to the chest size, again, it should be like 12 centimeter inside from the chest wall. And then it should be draining very well. So you can attach with the underwater seal, the tubing set over there. And then the last step would be to secure the drain, whether it is for pneumothorax or it is for pleural. Coming toward the algorithm of the pneumothorax pathway. So just a part of memorizing, when you are just observing any patient who came in with chest pain, ongoing shortness of breath, and you think of like it could be pneumothorax, always think of two things. Do a chest x-ray, look at chest x-ray, and then decide, is it pneumothorax or not? And if it is pneumothorax, whether you need to intervene or not. So these are two important questions you need to think of. And considering like if patient is a borderline patient, like in like 30s or 40s, and you're suspecting that it could be primary spontaneous because of underlying, or is it secondary spontaneous pneumothorax because of underlying any lung condition? So always think of these questions that is like in the yellow diamond box just below the spontaneous pneumothorax. The first thing, whether the patient's age is more than 50 years, number one, whether the patient is chronic smoker, if like normally he's 20 pack year history of smoking, and if he is known to have underlying lung conditions, like whether he's diagnosed COPD already on inhalers, or whether he is known to have underlying ILD. So if patient fall in this category, your prime diagnosis will be secondary spontaneous pneumothorax, not the primary one. And if he is not having any significant these sort of illnesses, and you found there is pneumothorax, the patient will fall in primary spontaneous pneumothorax. So these are like two categorizations. So that will split your ladder pattern down. So if it is primary spontaneous pneumothorax, once you've decided that this is primary, and then we need to go for measurement of the size of pneumothorax. So normally in UK, we are measuring at the Hyder level, but Americans, they usually measure at the apical level. So if it is more than 2 centimeter at Hyder level, then we are thinking, okay, that's the time we need to think of whether we need to intervene or not. So if it is primary, now we are discussing primary. If it is more than 2 centimeter, then patient is symptomatic. So now according to new guidelines and another important statement, which I have just make it a bullet points as well, don't intervene if patient is asymptomatic. Observe patient. If patient is symptomatic and you're thinking that the patient is having shortness of breath, having chest pains that's worsening, or very anxious at the moment, or he's developing some hemodynamic instability, like development of some hypotension or very tachypneic, then we need to intervene. So first intervention would be, if it is more than 2 centimeter in primary spontaneous pneumothorax, to go for aspiration. So either you can go with cannula or you can go with the robotic aspiration kit. So aspirate it and repeat a chest x-ray to look whether the size has decreased less than 2 centimeters or not. If the size has decreased less than 2 centimeter, then you can be reassured and the patient symptomatically improve. Then at that point, you can discharge patient, and we need to keep this patient as a follow-up patient. We will bring them in plural clinic, or even in if you are working in any other setup, so you can bring them in respiratory or even your own clinic to keep an eye on it, that this is not worsening, or there's no recurrence of whether it has complete resolution of the pneumothorax or not. So one important thing is it depends upon the timing as well. But we observe the patient is like having more than 2 centimeter, asymptomatic, or even if it is less than 2 centimeter. Sometimes the patients came over here and he's having ongoing chest pain and breathing difficulty, but you notice that it's less than 2 centimeter. We need to look at the time when the symptom started. If probably the symptom just recently started, we need to keep patient in for observation. So might be it will progress and it will develop more than 2 centimeter within almost like 1 hour, and then we need to intervene. There will be a point. Instead, we are just looking at this less than 2 centimeter. Oh, guideline says it's fine. We can discharge him. So it's better to just make decision depending on your clinical assessments instead of just blindly follow whatever the pattern is. Coming toward the opposite side of ledger, so that is secondary spontaneous pneumothorax. So now you realize that the patient came in more than 50, shortness of breath, background history of lung disease, whether it is COPD or ILD, and you have done a chest X-ray, and you noted that the patient's pneumothorax is more than 2 centimeter. That's a point in secondary spontaneous pneumothorax. You need to intervene. If it is more than 2 centimeter, you need to put a chest drain. And if it is 1 to 2 centimeter now, that's a difference as compared to the primary spontaneous pneumothorax. Then we can aspirate, we can give a single go. And then if it is resolving, again, we need to observe patient. If it is non-resolving, at a certain point we need to intervene and we need to put a drain in. So one last important point for primary spontaneous pneumothorax, if you're confident that after aspiration, the pneumothorax has decreased in size, we can discharge patient with reassurance and with safety netting. But in all cases of secondary spontaneous pneumothorax, whether it's more than 2 centimeter for chest drain, whether it is less than 2 centimeter, we need to admit patient for 24 to 48 hours, because that would be a point, because they are high risk for recurrence or for non-resolution of whatever the condition going on. Admit them for 48 hours, 24 to 48 hours, observe, and then if you're confident, we can discharge. So that was whole ladder pattern. Now coming towards like some actual genuine CT scans and some pictures we brought in for you guys to just be aware. When we are saying like chest drains is a simple procedure, it will be a matter of like 15 minutes. But if you are non-competent, you are doing out of hours, keep in mind it could lead to some worst complications, frankly speaking. Looking at this X-ray, the patient came in with pleural effusion. That was like pleural effusion on the right side, and the colleague just inserted a chest drain in. Look at the first X-ray. If you scan over here, so that's a point where the drain is coming in, and then look at the chest. The second scan, the drain tip is coming over here. The third scan, it is coming like into the liver, crossing over here. The fourth scan, crossing the liver as well, and even entering into the abdominal cavity. So that is a complication if it develops at that point. So rather than giving some benefit to the patient, we are giving them a more complicated. It can lead to some hemothorax, then hemoperitoneum as well, and then can traumatic liver injury will involve surgeons instead. And specifically, if it is out of hours, that will be a troublesome conditions, and we will be like in a situation where we will not have any supervision or any other senior who can help us out with that decision making. Any question over here, or we can go to the next slide?
Yeah, we can go. I think.
So next slide is here. This is another genuine X-ray for one of our patient. So some colleagues, they put a drain in for right apical pneumothorax. So the plan was to just put a drain in the apex. So unfortunately, it ended up into the lung. So I don't know how it happened, whether it was like after lung expansion, after putting a guide wire, the lung expanded and they just did, because normally the guide wire is blunted and it is not causing any traumatic injury. Whether the lung underlying was a bit like more diseased lung or pulla over there, or was it because of like introducer or dilators, they have just made a traumatic injury and then ended up in the chest. So be competent enough to do pleural procedures. If you're confident, and then definitely it's the best way to proceed and to relieve your patient. But if you're feeling you need some more supervision, or you need some more technical skills to improve. So make yourself a bit more competent before intervening. So we will bring up with the plan of post-procedure care. So these are very important. If you're doing for the procedure, you need to be very careful while securing your drain, because sometimes we noted the drain is, if for example, hanging outside, and if it's not properly secure, or even sometime in pleural effusion, there could be the dribbling of fluid outside, because we are making a proper track and we are giving a route of fluid coming out. So wound infection is very common, and if the you can see the chymosis over here on the back, that could be a complication of whether the patient was already on anticoagulants or not. If it is a post procedure, these sort of complications, we need to be very careful about all these things. So securing with proper stitches, with proper dressing, and daily dressing removal, and looking at this if need proper redressing, or need to clarify, or need to reposition the brain. It is very important thing to keep in mind. Okay. So I don't know how many of you guys have already gone through rocket pneumovent. So we used to use for ambulatory pneumothorax management over here. So I have just made bullet points according to the new standard guidelines. So always, if there is pneumothorax and you are planning to put a drain, instead of like putting a drain in, so best thing would be for ambulatory drain, and that is with the rocket pneumovent. It is just attaching over here. So normally this we are inserting in mid-clavicle line, second intercostal space, just inserting over here. It's a click sound. You are sure that it's a one-way valve effect. Inserting over here, attaching it with security, we can discharge patients. That's an ambulatory sort of drain. We can bring the patient in within like 24 hours, just to see did we achieve our goal, has already been like lung has expanded, so pneumothorax has already been resolved or not. Because sometime if it is not working very well, so ultimately we need to put a drain in, or we need to go for the proper procedure. But this is actually for the purpose of ambulatory uh, pneumothorax like treatments that we are normally doing over
I
here.
think it's very good. It's very small,
very
and
excellent,
patients
yes.
can go for shopping as well.
Exactly. So it's like very nice tool. This is just attaching over here. Initially, we used to go for the flutter bags and all this thing, like for ambulatory cure of pneumothorax. But it is just a simple step, inserting over here, attaching this with the skin, and then they are free to go, because this is one surety that one-way valve, definitely the patient will have air leak outside the lung, and there will be less building of more worsening of pneumothorax. So these are important points. I would say like a bullet points to keep in mind. So always think of conservative management for primary spontaneous pneumothorax. So look at it whether the patient need to be intervened or not. Number second thing, if it is the drain is needed, then consider ambulatory management of primary spontaneous pneumothorax. Like after respiration, we can send patient home and for re-observation, or pneumovent is the another tool to cure patient from pneumothorax. We are doing like attaching suction some patients who are having underlying secondary spontaneous pneumothorax or primary spontaneous pneumothorax. They are not resolving, lung has not been expanded after 24 to 48 hours. If they are not improving, then we are attaching a high volume low pressure section, normally starting with 1 or 2 kilopascals. So if it is not improving, then ultimately next step would be to refer them to surgeons, so to proceed with whether it is like a surgical procedure, we need to intervene if the patient was the first presentation or repeated recurrent pneumothorax, and then will be the surgical intervention. Sometimes, if the patient are presenting with even first episode of pneumothorax that is not resolving, or secondary spontaneous pneumothorax, at certain point we need to we intervene with pleurodesis, whether it is like talc pleurodesis, if it is like recurrent pneumothorax, and specifically empyema or malignant pleural effusions. Initially, we used to go with talc pleurodesis as well, and we need to refer some patients to surgery if it is not resolving the simple interventions, and surgical treatment, whether it is pleurodesis or bullectomy in case of COPD underlying. That will be the next management plan after your medical management. For any patient who is having second episode of pneumothorax, whether it is ipsilateral pneumothorax second episode or second episode of contralateral, they need surgeons. These are some important points. This was all for pneumothorax. Now we are heading toward pleural effusions. So I've just added on some ultrasound images to get an idea. You can just look how we are putting a probe on. So this one where the mouse is at the moment, that's a pleural effusion. The anechoic or hypoechoic shadowing over here. So that is like a black shadow you will find. Skin is on top along with the pleura over here. And lower surface, that would be the lung, if that's pleura. So this one is the diaphragm, the white rim, just above the, sorry, it's coming up. So liver along with the sinusoids, and the white rim is the diaphragm. Above diaphragm is the pleural effusion. Normally, we shouldn't find this black anechoic shadowing because of the lung tissue over there, and the tissue density is just like liver. The shadow, we couldn't find any black shadowing over here or anechoic shadow. So this actually reflects the pleural fluid collection, and normally we measure it, the size and depth of the fluid according to the numbers, how many centimeters, and sometimes we are measuring the rib spaces, how much is the fluid, and what is the ideal intervention, what is the maximum point where we need to intervene. That is just to get an idea. Next images. So that is to give you a proper idea about the pleural effusion over here. That's a black shadowing along with collapsed lung underlying, and the diaphragm and liver on that side are spleen. It depends on which side of the scan is this one. Here is another idea about the collapsed lung, diaphragm. There is some fluid collection under the diaphragm above the liver, so we can get an idea that could be an element of ascites as well. And pleural fluid is always above the diaphragm of fluid collection. That's the black anechoic shadowing. So this gives an idea if you are ultrasound trained, then to intervene. Otherwise, normally back home we were just with percussion method we were going to intervene. But here we need to be ultrasound trained before any sort of pleural effusion interventions. If you're not trained in and you're confident to perform a procedure, ask someone to just point it out for you, mark the point of insertion, and then intervene. So that's another image of complex pleural effusion, multi-septated or multiloculations over here, or septated effusion. So this is a complex sort of effusion, whether it is parapneumonic or prolonged effusion that is over there, that need intervention. Normally I've seen they are ending up with the surgeries because tube, if we are inserting, they're just inserting it or entering into the single pocket, drain the single pocket, but other pocketing. So just to get an idea about how it looks like a septated or multiloculated effusions. So now coming toward the pleural effusion pathway. So if it is pleural infection you are suspecting, according to the recent guidelines, if you're suspecting it is pleural infection or looking like empyema, or if it's like complex parapneumonic effusion, so what should be the plan of management? You have just done with your chest x-ray, blood investigations, creeping up inflammatory markers, you're thinking of probably it looks like more empyema. The next thing would be to scan and do diagnostic aspiration. The diagnostic aspiration will give us an idea about the pH of the pleural fluid. So then it is dividing whether it's the pH level is less than 7.2, it is like 7.21 to 7.39, intermediate risk of this CPPE, that is complex parapneumonic effusion, or if it is less than 7.2. So that gives us an idea. If it is less than 7.2, then definitely it is empyema, and then you need to insert intercostal drain. If the fluid pH is 7.21 to 7.39, so that's intermediate risk, then we need to look at the LDH levels and other parameters like patient's inflammatory markers on scan, if there is like high contrast enhancement of pleural levels, if it is multiseptated lesions according to the ultrasound, and then you can look at pleural fluid LDH levels as well, because once you have aspirated, you have already sent for the fluid analysis, and if LDH is more than 900, need to intervene. If pH is less than 7.2, intercostal drain. If it is intermediate risk from 7.21 to 7.39, look at the LDH and inflammatory marker patterns. If it is suspicious of empyema or complex parapneumonic effusion, need to insert ICD at that level. Our other way, if it is LDH is even less than 900, need to look for the glucose levels as well. If glucose is less than 4, that's coming up in this second intermediate slide. Sorry, for this one. I think it's a bit zoom in. So then we need to intervene. Suspicion of empyema is over there as well. But if it is less than 7 point, it is the pH is more than 7.40. That is it's convincing. Maybe we can observe patient with follow-ups, with observations, or maybe we can treat and then we can repeat X-rays to look for complete resolution of whatever the paranormal fields are. So that is a pattern you need to think of if you're thinking of pleural effusion, whether it is like hyperdense or opacity over the chest X-ray, and you're thinking of could it be pleural effusion? If you're confident enough to go through ultrasound, get an idea. Otherwise, look at this, whether you have treated it or not. We can take pleural aspirations to look for analysis, look for pH, LDH, proteins, glucose, and then observe this one, whether the patient need intercostal drain or not. Or if not for intercostal drain, we can bring the patient in for another follow-up X-ray to look for the resolution that the patient has resolved or not. Okay, and this is like a surgical interventions. I think if the patient has complex multiloculated effusion or septated effusion, and then when we need to involve surgeons in that, if on initial presentation you've noted the patient has multiloculations, septations, and sometimes the patient have non-resolving, previously have been treated as well, then even on first presentation or first interaction with the clinician, they can send it to surgeons, considering that the patient may need some surgical interventions, whether in the form of like decortication or pleurectomy in that scenario. But otherwise, I think I'm unable to look at these central lines, but there is some scenario. If there is some multi-septation, so you need to think of whether we need to insert for TPDNAs as well. So tissue plasminogen activator, like in the action of fibrinolysis to decrease septations, or even in case of malignant pleural effusion, sometime, even if the patient is waiting for a surgical intervention or waiting for the surgical procedures, they can insert TPDNA, DNAs. So in that scenario, just to get an idea, basically, what will be the solution if you initially thought it could be malignant pleural effusion, or if it is like multiseptated, when to refer to surgeons to need to get an idea. I think this slide will give you a proper clue about that. So in terms of pleural effusion, the important point, similar as like it was in pneumothorax. So always, whenever you're intervening, you're doing diagnostic procedure to check pleural the fluid pH, and then LDH is important according to the ladder pattern, glucose and protein levels. Sometimes, if you are a bit unsure if pH is falling in between 7.25 to 7.35, must pair with the serum levels as well, serum protein LDH, to properly fulfill the Light's criteria and to get an idea whether the fluid is falling in exudative or transudative criteria. TPA-DNAs for where you think there is persistent loculations or fluid collections over there, but it's not draining too much, and you are thinking of complex effusion with septations. So then we need to add on some fibrinolysis, but definitely we need to consent patient for that, and we need to discuss all the complications related to that. If it is large pleural effusion, then think of according to the facilities available. If you have facilities, better to proceed with medical thoracoscopies instead of going through simple diagnostics, because yield is better for medical thoracoscopy. We can send for cytology and histology as well to get a proper conclusion instead of doing multiple interventions on that pleural effusion. We are using IPCs, indwelling pleural catheters. I think you've delivered a presentation on indwelling pleural catheter for malignant pleural effusions. And that is like a proper beneficial effect for those patients who are diagnosed with malignant pleural effusion, whether it is the lungs are associated with some other malignancies ending up with the pleural effusions. So IPC is a beneficial thing. Whether we can choose pleurodosis with IPCs or not, it depends upon case. It varies basically case to case. Last thing would be surgical referrals, and that I think I have added on the slide. If you can quickly go through it, so you will get an idea what are the patients who are suitable candidates to whom we can refer to surgeons for decortication or pleurectomy if it is non-resolving, despite putting a drain in, or despite if they're ideal candidate, whether on first presentation or on recurrent presentations, we are not improving that. So that's it. I think we have discussed like indications, contraindications, steps of prepping the trolley and all the equipments, and the steps of procedure, how to intervene, the 7 steps need to keep in mind of those 7 steps. I think that was all from my side, but one more thing which I need to just mention about the post-procedures care. So that is very important. So post-procedure, on very first day, always document in case of pneumothorax that whether the tube or maybe the when you have put the underwater seal, whether the column is swinging or if it is bubbling or not, you need to document this one. Observation should be every 15 minutes for first hour, and then every hour for the first 4 hours, and then every 4 hourly, at least for one day. And then because observations could give you an idea whether the procedure went very well or if the patient is developing some complications, they can have like desaturations, tachypnea, tachycardias. They can get us an idea that we need to further intervene in that scenario or not.
I think this was a very concise, summarized presentation, and the take-home message would be to practice, revise, step in your mind before going to the procedure, and then do ultrasound guided.
Yes.
If you're not sure, ask for help from the seniors.
Exactly.
And then post-care, post-train care, very
Yes,
important.
it's very important. One thing is another to add on, that is avoiding out of hours. So that's a very important thing. I think that's all.
Thank you so much for your valuable time. Thank you.